Hello, my name is Rachel Angelo, and today I will talk to you about Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome is a pediatric overgrowth syndrome that affects many parts of the body. It is considered a clinical spectrum because presentation varies from severe with many clinical features to mild, consisting of only one or two. It was identified in the early 1960s by Dr. J. Bruce Beckwith and Dr. Hans Rudolf Wiedemann. They noted children with this syndrome to have macrosomia, macroglossia, and abdominal wall defects, specifically omphalocele and umbilical hernias. But since then, other clinical features and presentations, such as hypoglycemia, enlarged adrenals, and hemihypertrophy, have been included in the classification of Beckwith-Wiedemann syndrome. Children with this syndrome are at increased risk for tumors. Tumors develop in about 10% of people with Beckwith-Wiedemann and almost always appear in childhood. The average life expectancy for Beckwith-Wiedemann syndrome is usually normal. Life-threatening risks occur in childhood. However, at about age 8, growth starts to slow down, and the typical clinical features of Beckwith-Wiedemann as well as tumor risk also decrease. Beckwith-Wiedemann syndrome affects 1 in 13,700 newborns worldwide, although it is thought that the number may be higher because people with mild symptoms often go undiagnosed. And interestingly, assisted reproductive technology increases the risk of having Beckwith-Wiedemann syndrome. Incidence in children conceived through ART is 1 in 1,200 compared to 1 in 13,700 newborns in the general population. Phenotype of Beckwith-Wiedemann includes macrosomia, as you can see in the infant on the top left corner of the slide. This baby exceeds the 95th percentile in height and weight. You also see macroglossia, and that's severe in the infant in the middle of the slide. That can affect airway patency. Abdominal wall defects such as omphalocele is also seen with Beckwith-Wiedemann. You can see that in the infants on the bottom left corner of the slide. And in the bottom middle corner of the slide, you see a toddler with creases or pits in the skin near the ears. This toddler has a milder form of Beckwith-Wiedemann syndrome. Hemihypertrophy is also seen with Beckwith-Wiedemann. That is excessive growth that is unilateral. It causes asymmetry in the body. Children with this presentation usually have problems with gait. Other clinical presentations include hypoglycemia in the neonatal period. We will most likely see those babies in the NICU and treat them. Kidney abnormalities, which include nephrocalcinosis, nephromegaly, and later on medullary sponge kidney. Neoplasias such as Wilms tumor, hepatoblastoma, neuroblastoma, or rhabdomyosarcoma are also seen, and visceromegaly involving one or more intra-abdominal organs, including the liver, spleen, pancreas, and adrenals, are also seen. Diagnosis is made by clinical presentation of major and minor findings, and they can be confirmed by genetic testing. Testing includes DNA methylation studies, single gene testing, chromosomal microarray, karyotype, and multi-gene panel. Because it is a clinical spectrum disorder and there are varying degrees of clinical presentation, clinical diagnosis and confirmation with genetic testing is really dependent on doctor or practitioner assessment and suspicion for the syndrome. In the past, there was no consensus on clinical diagnostic criteria for Beckwith-Wiedemann syndrome, but in 2018, an international consensus group met and released a statement in which they agreed upon 72 recommendations for clinical and molecular diagnosis and management of Beckwith-Wiedemann syndrome. Now I will discuss the genetic mechanisms and abnormalities of the syndrome. Beckwith-Wiedemann syndrome is genetically complex. The chromosome associated with the syndrome is chromosome 11, and the region affected in chromosome 11 is the 11p15 region, which is considered an imprinting center. So to briefly review, people normally inherit one copy of chromosome 11 from each parent. For most genes on chromosome 11, both copies of the genes are expressed. But for some genes, only one copy is expressed. It's either from the father or the mother. And this phenomenon is called genomic imprinting. So as you can see in the pie chart, there are many mechanisms associated with the syndrome. 50% of Beckwith-Wiedemann cases is due to abnormal methylation at the imprinted region. 20% is due to paternal uniparental disomy. 17% is unknown. 10% are from the gene CDKN1C mutations, and then the remaining 3% are due to translocations, inversions, and duplications. The genes that I listed next to the pie chart are associated with growth, and they are located in clusters in the 11p15 region of chromosome 11. So, epigenetic and genomic alterations in the short arm of chromosome 11 at the position of 11p15 are associated with Beckwith-Wiedemann syndrome. Now I will briefly go over phenotype correlation to genetic mechanism. As I stated previously, 50% of Beckwith-Wiedemann cases are a result of abnormal methylation at the 11p15 region. Phenotypes associated with abnormal methylation are neoplasias, omphalocele, macroglossia, macrosomia, and visceromegaly. This region has clusters of genes associated with growth. Methyl groups can either activate or repress genes. If you look at the diagram on the left, Part A represents a map of the normal chromosome 11p15 imprinting region. The colored areas are areas that are activated. The lower two diagrams, B1 and B2, show abnormalities in methylation, where in B1, the gene H19 gains methylation, and in B2, KVDMR1 loses methylation. I will discuss both scenarios. When the gene H19 gains methylation, it activates the maternal IGF2 gene. And if you look at the diagram, the paternal IGF2 gene is already expressed. IGF2 plays an essential role in growth and development. Now you have both maternal and paternal IGF2 genes activated, and that results in overgrowth, as is seen in Beckwith-Wiedemann syndrome. In B2, maternal KVDMR1 loses methylation. This affects the maternal CDKN1C gene, which is the gene that is imprinted. It silences the gene. CDKN1C provides instructions for making a protein that acts as a tumor suppressor and regulates cell growth. It controls growth and prevents the fetus from becoming too large. So when that gene is repressed, you will end up with a macrosomic baby. Take-home note is that these imprinted regions in chromosome 11 are delicately balanced, and abnormal methylation disrupts that balance. It disrupts regulation of these genes and results in overgrowth and other features of Beckwith-Wiedemann syndrome. 20% of Beckwith-Wiedemann cases are a result of paternal uniparental disomy. That's a condition in which both copies of a chromosome are inherited from one parent, in this case the father. Phenotypes associated with UPD are a high risk for Wilms tumor, hepatoblastomas, and hemihypertrophy. Phenotypes associated with other causes include neuroblastoma, cleft palate, which is rare, omphalocele, brain abnormalities involving the posterior fossa, macroglossia, and macrosomia in mutations in the CDKN1C gene. Also, macrosomia, macroglossia, developmental delay, and positive family history occur in duplications and deletions in chromosome 11. Inheritance pattern. 85% have no family history. It is sporadic. And then 15% have a family history, through the autosomal dominant mode of transmission. Management strategies and considerations are treating phenotype and clinical presentation. So you want to treat hypoglycemia in the neonatal period. Surgery is performed for omphalocele, tongue reduction, and also to equalize significant differences in leg length. Intubation may be required in the neonatal period if airway is compromised due to macroglossia. Speech therapy is often needed after tongue surgery. Neoplasias are treated as per pediatric oncology protocols. And then referral to specialists such as nephrologists, endocrinologists, and oncologists. Surveillance includes monitoring hypoglycemia, abdominal ultrasounds every 3 months for tumor screening until age 8, monitoring serum alpha-fetoprotein levels every 2 to 3 months in the first 4 years of life. This allows for early detection of hepatoblastomas. You also have annual renal ultrasounds for affected individuals from 8 years to mid-adolescence to check for nephrocalcinosis or medullary sponge kidney disease. There are psychological and social effects on kids and families with Beckwith-Wiedemann syndrome. Children are teased in school because of protruding tongue and constant drooling, and also because of hemihypertrophy and body asymmetry. Parents worry about tumor risk, and depending on severity of clinical presentation, there are many visits to specialists and also surveillance testing that is done. Financial considerations include the cost of surgery, include follow-up visits to specialists, lab testing, ultrasonography, and then ethical considerations. So assisted reproductive technology entails a 10-fold risk of Beckwith-Wiedemann syndrome. Prenatal testing is available. For a couple that undergoes ART, if there are positive results for Beckwith-Wiedemann syndrome, do they terminate the pregnancy, given the possible difficulties in childhood that their infant would be subject to? Or do they continue the pregnancy in hopes that clinical presentation is mild, and knowing that it is mainly a childhood disorder and that life expectancy is usually normal? This concludes my presentation. Listed are my references, and I hope you enjoyed listening to the presentation. Thank you.